Welcome, everyone. This is the April 1st Opioid and Prescription Drug Abuse Advisory Committee. Glad you all could join. I know this is a holiday week. We're just thrilled. We've got some great presenters, and we hope to have a great discussion this morning. I'm Alan Della Penna. I'm branch head for the Injury and Violence Prevention branch, and I serve as the host for the OPDAAC meetings. So we have a team that's been working hard for a while to put together the agenda. The theme for today is pregnancy and substance use, and Margaret Bordeaux is going to be the moderator for most of the session today. But as we've done in the virtual environment, some folks may attend these meetings regularly, some this might be new to you. We like to know who the audience is. It helps the presenters. It also helps us know who's joining in and attending. So we're going to have a poll for the participants. I see the numbers keep rolling up as folks are joining. So if we could put the poll up and just identify what you see yourself, what sector you see yourself falling into. We'll give that a few moments as folks continue to join in. While the poll's going on, I'll also mention, and this will be mentioned again at the end of the meeting, that we try to hold these OPDAAC meetings roughly every other month in the virtual environment. When we're in person, a year ago, we were meeting at McKimmon Center. We have a semi-annual prescription opioid summit, and our summit is coming up in early May, and there'll be registration information at the end of that. If y'all aren't aware of the summit, this list for joining, you'll be added to a list and you'll get registration information. So sessions like this, there'll be much more opportunities over 3 days at the Opioid Summit, May 4th, 5th, and 6th. Is that right, Sarah? Got it. Okay, so thank you. This gives a chance to see who all's represented in the group today, and we really appreciate that. So how we work these meetings, everybody now is, I think, pretty familiar with web conferencing and so forth. What we have two functions. During our speakers' time, there's a Q&A button at the bottom of the screen. There's also a chat button. If you have a question for the speaker, please put it in the Q&A, because the chat starts getting filled up with a whole lot of conversation. It's fabulous to have. We have some of our team that will be monitoring the Q&A and the chat, and they'll be live answering questions, but also we'll have a time at the end of each speaker's time for one of our team to read off the questions. So there's plenty of time to give feedback to folks and kind of use this as a learning experience. If you're more comfortable with chat, we'll be monitoring that also, but in this format, we're trying to use the Q&A as the way to direct questions to the speakers. So, Sarah, am I forgetting anything up front? I always rely on Sarah Smith, you might have gotten emails from on the coordination of this. You good up front? Okay. Well, it's my pleasure to turn this over to Margaret Bordeaux. Margaret.
Thanks, Alan. Good morning, everyone. I'm going to be your moderator for today. Thank you, Alan, for that introduction. At this time, I'm pleased to introduce our first speaker, Judith Johnson-Hostler. Ms. Hostler is a master's level clinician who has worked in the field of addiction for over 20 years. Presently, Judith is employed at the Alcohol Drug Council of North Carolina as the coordinator for the state's Perinatal Substance Use Project. Thank you so much for being with us this morning, Judith.
Thank you for having me, and I'm really glad to be here. Alex, if you can go to the next slide. Okay, the next one. So today we'll cover North Carolina's resources for women that are pregnant or parenting, and also we'll cover how to access those programs throughout the state. We can go to the next one. So why is it important to be gender responsive? So gender responsive services create an environment that reflects the understanding of reality for women. lives and addresses women issues, and gender responsive services helps improve the effectiveness of services for women. So learning about implementing gender responsive principles will help you improve prevention, treatment, and recovery programs for the women and girls that they serve. Now, we're not saying that every, in our program, the state's programs, we're not saying that that everyone that works there is a man, a woman, but we have men and women that serve these women in these populations. And gender responsive is a broader way of looking at services, environment, and the experiences that women have. You can go to the next slide. So the Perinatal Substance Use Project. This project provides screening, information, pregnant and parenting with dependent children. We provide consultation, training around technical assistance like we're doing today, public health, for public health, and for anyone that's interested in learning about the women's programs in North Carolina. There's a weekly bed availability that goes out. So often I'll hear people say, oh, hey, I wasn't familiar with all the programs that North Carolina have. We have a lot of programs in North Carolina that serves women, and they do an excellent job. The bed list goes out every week. It's updated with what is available in the state, their waiting list, who is being admitted, and what referrals are pending. If you're interested in being on the bed list, now you might not be, but maybe someone you know, have them send an email to jjones@alcoholdrughelp.org. And with being on that bed list, you would also get any type of training that comes up around gender responsive care. That's another thing that I make sure that any of the trainings in the state goes out to that bed list. We have over 600 people at this time that are on the bed list. The 1-800 number, 1-800-688-4232. This number is answered by the Alcohol Drug Council. Now, there's always a live person from 8 o'clock to 6 p.m. that responds to this number. However, after hours, there's an answering service. If the woman is pregnant and she gets to the answering service, they will send her to me. And it doesn't matter if it's 3 a.m., I will get up and answer that phone call to try to help her get connected to some services in North Carolina to make sure she's safe. So if we can't do anything, she's not going in treatment at 3 o'clock in the morning, but we can refer her to the emergency room and make sure she's safe. So again, that number is 1-800-688-4232. And I'll talk a little bit more about the services that Alcohol Drug Council offers at the end. Alex, you can go to the next slide. So this map is a map that looks at the programs in North Carolina, how they are geographically positioned. So I would say, if you look at this map, there's only one program, actually an outpatient program, and one residential program in North Carolina and in the western part of the state, which is in Asheville. That's Mary Benson House. But you see that we're covered pretty much everywhere in the state. These state programs are offered for the women. So the middle part of this slide is the outpatient programs that also provide gender responsive care. One of the issues that often comes up is that the women that are in the western part of the state, they don't like to leave that area. So that you'll notice when you see the bed availability that they always have a high number of folks on their waiting list. And what I do is to encourage them to at least maybe go to the next program that's closest to Asheville, which is Charlotte. And sometimes we're able to convince them. So I'll go to the next slide. So the North Carolina Perinatal and Maternal Substance Use Initiative. When you hear people talk about the program, they always say the CASA Works programs. Well, CASA Works, they're not all CASA Works. CASA Works, I'll explain that in one of the slides, but some of the programs are for, they're listed on the bed availability as perinatal or maternal. And on the bed list, it will give you a description of the requirement to enter into these programs. For example, on your perinatal beds, you would have a description that the woman would have to be pregnant or postpartum. And each program may be different. So one might say postpartum 3 months. One might say up to 9 months. So it's important to look at that bed list or at least contact me so you'll know the specifics of it. Some will believe that only 2 children could come to the program. That is not something that's a rule. The rule is that we need to have the appropriate square footage for each apartment. So if the person has 3 children, it is dependent on the genders of the kids, the age, the size of the apartment. So you want to reach out to the program to get the specifics of if there's availability at their program. If not, you can contact me and then we'll search around and see who has larger units. The other thing is that there are cross-area service programs. That means that any woman in the state of North Carolina that is able to give residency here, that she's able to access any of those programs in the state. So if she's from Wake County and we have a bed available in Mecklenburg County, doesn't matter if her Medicaid is in, if she has Medicaid and it's in Wake County, then it would be changed when she gets to that other county. Now, sometimes we run into areas where we don't have a contract with the LME-MCO, but that is not a barrier either. That can be addressed with the appropriate phone calls to my manager, who is Starlene Scott Robbins. She's the coordinator for women's treatment for the state. So the services include, so now there is a difference. I want you to know that there is a difference between the Perinatal Substance Use Project, that is with the Alcohol Drug Council, they have that contract, and the North Carolina Perinatal Maternal CASA Works initiatives are the state's programs. Okay, so with these programs, there's screening, assessment, case management. The woman has to have a ASAM criteria, which it is usually 3.5. She meets the requirement for those programs. The children are also, there's also case management for the children. Now, the one program, I mean, some of the programs are able to offer daycare, but I will say UNC Horizons has a therapeutic daycare. It's absolutely beautiful. And so the children also benefit from services provided by the local health department. So the next slide, Alex. Okay, so the NC CASA works. So the first programs we talked about was the perinatal maternal programs, and the NC CASA works. So this is a philosophy that treatment is work and work is treatment. Some programs, you might look at the bed list, and on the bed list, let's say for instance, the Village. So the Village has the perinatal project, they have the maternal, and they have the CASA Works. So CASA Works is for women with children. The children are up to 11 years old. As I mentioned, it could be more than 2 children. So CASA Works is treatment is work and work is treatment. Usually what happens is they complete their SAOP or SACOP portion of treatment, and then they go to work. At this time, things are a little different because of COVID, but job readiness is still a part of that. So 7 comprehensive residential programs for women with primary substance use. And again, they are all cross-area programs. They're all CAS. Next slide. I'll talk a little bit about the alcohol drug treatment centers, the OPDAACs. So with the OPDAACs, there's 3 of them in the state. Julian Keith is in the western part of our state. R.J. Blackley is pretty central, that is in Butner, and Walter B. Jones is in Greenville. The client that would access these beds, so if I had a client that contacted the 800 number, and this mommy was pregnant, and she was also using heroin, IV, or maybe benzodiazepines, she would be referred to one of the OPDAACs. And that would have to occur because we don't want her to go directly into one of the programs, because if she's going into the program and she's not stabilized on either buprenorphine, Subutex, or methadone, then that would not be good for her or for the program. So we want to make sure she's stabilized first before going into the program. So we would I would be a liaison to connect her to treatment at Walter B. Jones or one of the other programs. Now, Walter B. Jones is the program that will take them. All of them will take pregnant women, but Julian Keith and R.J. Blackley have a cutoff, but with Walter B. Jones, she's able to go all the way up to the end of her pregnancy. So if she is 37 weeks pregnant, she's able to access those beds there as long as there is availability. Now, I think, okay, Alex, you can go to the next slide. So this is a resource for you to check out. Now, one of the things I do want to mention, I didn't mention it. So the layout of the programs are their apartments, and they're also communal living where there's houses. So when you look at the bed list, if you happen to get to be added to the bed list, or you're interested in receiving brochures as far as electronically, on the bed list, anything that says house, so you have Mary Benton House, Kelly House, and our house. Those are the only 3 that are a house setting with women share living, communal living. The others are apartments, so they would have their own apartment. And I just failed to mention that to you. So this slide is the North Carolina Pregnancy Opioid Exposure Project. It is a great resource for you to have. It is a resource that provides guidance for the provider around opiate use in pregnancy. It provides guidance for your client, and also guidance around neonatal abstinence syndrome. On this resource, you can also see, you'll see a couple of videos. There's one video of myself, which is the Perinatal Substance Use Project, talking about that project and how it works. And then the other video is a video of motivational interviewing. And then there is the map. So you can hover over the map and be able to see the resources that are in that area for the clients that you serve. Next slide. This is the Alcohol Drug Council slide. I did mention that they have other resources there. So they have the information and referral line. So the information and referral line, most of the people that work there are either peer support specialists or CADCs. Some of them have lived experience. And we have a National Guard program there, and also the Perinatal Substance Use Project. You notice on this slide, it says that they have tech support line. The Perinatal Substance Use Project does not, I don't participate in the tech support because of confidentiality for the clients we serve. And hold on a second, Alex, my plug look like it's trying to go off. So give me 1 second. Please give me technical grace. Thank you. So that is, as I mentioned, they have 24/7. Someone is responding to this line. So either a person or, I mean, it's a person or the answering service. If you're looking to, if you have a client, a woman, maybe her spouse or her partner is looking to go into treatment, contact 1-800-688-4232 and they'll be able to help you get connected. And the next slide, I think this might be it. Oh, no. This is Proof Alliance. This is their new slide. Proof Alliance was the FASD project. So it is still the FASD fetal alcohol spectrum project, but they have partnered with ARC. Amy Hendrée, who was the director for FASD, is still a part of this program. She's the she is the trainer coordinator now, and it's called Proof Alliance. You'll be hearing a little bit more from them during the year. What they're doing right now is doing train-the-trainer. I'm one of the trainers that will be participating with them, but they're doing a train-the-trainer so that they're able to offer more resources around fetal alcohol spectrum disorder through the state. Next slide. And that's it. Thank you for having me. Alex, if you can check to see if there's any questions in.
We do have questions, Judith, and thank you so much for your presentation.
Thank you.
One of the ones that came through the chat is, what assistance is provided with transportation? And so part of the concern for women in Western North Carolina is that lack of transportation. See if you'd be willing to answer that.
Well, that's always an issue, but I'm gonna tell you, if you contact me, if you're able to keep my number in speed dial, I will work really hard trying to find some type of transportation for her. So when I say try to find transportation, sometimes medical assistants have, if we had a woman that needs to go to Walter B. Jones, we've been able to connect them with transportation through Medicaid. So medical transportation. If they're able to get to, say if they were able to take a train to Cascade, the program will pick them up at the train station or the bus station. So, or they could reach out to people in their community. Sometimes faith-based communities have an ability to connect them with transportation, but that is always one of the barriers, is transportation. It always comes up in any training. Is it another one? That's it?
Well, I have something else I want to ask, and I know we'll get to it in the next presentation, but just really, can you speak to the importance of treatment and medications for opioid use disorder for women and for people who are pregnant? Yeah.
It is, it's very important. I remember when I started, I've been in the field now in almost 30 years. I am a woman in long-term recovery. I've been in recovery since 1991. So this year I'll have 30 years, and I came pregnant. I was someone that worked in, I was in that era where there was it wasn't the opioid era, it was another era. And so the difference was I connected with someone that I worked with, a nurse that I worked with. I was a lab tech, and just the way she talked to me and with me made a difference. And so when I started, it wasn't working as a counselor. It wasn't okay for clients to be in treatment on medicated assisted treatment. It wasn't something that we approved of. And that was ridiculous because we were losing them. And so now we have, it's the Moms Project has been around forever. Hendrée will talk about the importance of it, but we know it's important. I remember even when I started working as a counselor, it wasn't okay for someone to be on medication. It wasn't okay for them to be on psychotropic medications. So we were losing clients back to substance use. And so we know that today we have the resources. There's all types of research that shows it's safe. And in it, there is a opportunity to explain to the woman what will happen. Andre will probably mention it, but one of the things that they do is that their women are able to tour the hospital. So they know what to expect. It's not something that's a surprise to them, but medication treatment is very important.
Thank you so much, Judith,
You're
for
welcome.
sharing that. When you get an opportunity, please check out the chat. Lots of good, kind words for you there. So thank you so much for sharing. Yeah, and thank you for your presentation. I have one more question, and after that, we'll be ready for the next presentation. Are there residential programs for mothers with children that are over the age of 11? Or what resources and services are available?
So what I've done is that when I am referring them to other resources, I try to make sure I know what those places look like, who is serving them. So there is a program, and they're not one of the state programs, but however, they may receive some state funding. Hope Haven. They will take up the whole family, a husband and a wife and children, and they will take older children. You have a program in Durham that will, I think it's called Turning Lives Around. It used to be called the Genesis program. Now that is for homelessness, but then you can connect mom to outpatient treatment. So there's ways to connect them. If they have a child that is 11 and pretty close to 12, like as I mentioned earlier, Starlene Scott Robbins is the coordinator, and she's my manager. She could make the decision to allow mom to take the child with them. But anything beyond that, I believe that the history was they did try to take older kids in the beginning, but all kinds of issues showed up, and so there's cutoff. Yeah.
Thank you. It's a really great explanation. And thanks for sharing those additional resources that are somewhat outside of the network, but still very important to this population.
You're welcome. Thank you for having me again.
It was our pleasure. So right now, I'll introduce our next presenter, Dr. Hendrée Jones. Is internationally recognized expert in the development and examination of both behavioral and pharmacologic treatments for pregnant women and their children in risky life situations. She has received continuous National Institutes of Health funding since 1994 and has written more than 200 publications. Dr. Jones is the Executive Director of UNC Horizons and a professor in the Department of Obstetrics and Gynecology, School of Medicine at the University of North Carolina at Chapel Hill, North Carolina. It is my pleasure to now turn it over to you, Hendrée.
Thank you so much, Margaret, and thank you, Judith. I always learn something from your presentation, no matter how many times I've seen you. So thanks for that beautiful state overview. And so we're going to we've gone from the macro of the state now to the micro, where I'm going to share what we do at Horizons, and then I'm going to turn it over to the real stars of today, which will be two wonderful women with lived experience that are going to talk about parenting and substance use disorder. So next slide, please. So for the objectives today, I just wanted to share some about our model that has been used to help women, both pregnant and or parenting, who have a variety of substance use disorders. We'll definitely focus on opiates, but just want to acknowledge that we take any person that identifies as a woman who has a substance use disorder, pregnant or parenting, with all different types of substances. We'll share a little bit of data from our program and then touch on some lessons learned and future directions. Next slide, please. So where did we start, right? So as Jude mentioned, there's a whole number of different programs in the state, and UNC Horizons was one of the first ones. We've been around for 28 years now, started by Connie Renz and Dr. John Thorpe as our founders. And so it was really started with state money because they recognized that there was a problem of untreated cocaine use disorder in our state, and there were high NICU stays, and lots of dollars were going to that. So putting money towards a solution, and a number of programs were started, and so we were one that was part of a medical university. So since that beginning time, we've treated well over 5,000 individuals from every single county. We've had the pleasure of touching people there. Started with residential in 2001. And kind of where our money comes from, our block grant, state funding, as well as Medicaid, a variety of different sources. And we have a growing, privately supported boutique programs that we're doing for women, addressing things like educational barriers, as well as a newly funded housing barrier. Next slide, please. Yep. So who do we serve? On average, with the exception of COVID, we serve about 230 women a year. Women come to us usually in their late 20s. Everybody that we take care of either comes to us with no insurance or has Medicaid already. About half of our patients are pregnant, and well over half come to us with Child Protective Service involvement. And we have really important outcomes to share around that. I have to say, the 25 years that I've been doing this work, finding a woman that is using substances and becomes pregnant, it is usually not one substance that she's using. Usually it's a variety of substances. Well over 85% of our women come using tobacco products, as well as about a third use alcohol, and then a whole different type of different substances. Opiates, of course, have been the one that has received the most focus, for which we do have medications to treat it. Methadone, as well as buprenorphine, have been repeatedly shown to be relatively safe and effective during pregnancy, both for the mother as well as for the fetus and for the child later on. We know that the women come to us often having grown up either in the Child Protective Service system or in families that have had active addiction too. And so part of what we work on is that intergenerational piece to help support women and empower women to be the best parents that they can be and the type of parent that they want to be. And maybe that's not the type of parenting that they experienced. We also know that many of our women have been a part of the legal system, and you can see there the number of arrests. And trauma, that experience of physical, emotional, and or sexual abuse as children, as well as into adulthood, is something that is incredibly prevalent with the patients that we have the honor of serving. And so we work a lot around that and how to recognize that you are not your labels, you are not where you came from. You can really chart your course any way you want to from this day forward. Next slide, please. Oh, keep going, just go until the thing stops. So this is just our model. So we are founded on a philosophical approach of social learning, female empowerment, and relationship theory, because we know so much of what we experience through life is through relationships, it's through communication. And so we talk about what the role that is that substance use has played in a woman's life, how it's playing out with her children, perhaps making sure that everybody has that opportunity to really thrive as individuals. We provide that trauma-informed addiction services, both group as well as private or one-on-one. As Jude mentioned, we have our 5-star licensed child development center where all of our children can be screened and assessed and then get the services that they need. We also provide transportation to and from the program. We have a wonderful volunteer who provides some legal aid services for us, and then we can also hook women up with other legal aid services that they need. The biggest barrier that we face is housing, and we actually have an initiative right now in Chapel Hill, partnering with the Chapel Hill, the town of Chapel Hill, as well as some other community partners like CASA and Self-Help, to start to address that really big barrier. But that's the hardest thing that we face in terms of helping keep women well and in recovery when you don't have a stable place to live when you leave the program. We also provide parenting education and process groups and in-home visitation for our residential families and early intervention services. And then our lowest level of care is actually our integrated perinatal clinic, where when women come, either prenatally or postpartum, they're going to see an OB provider, they're going to see a case manager, and they're going to see a therapist. We also have psychiatry services that are available for our pregnant and parenting patients. And then obviously medication-assisted treatment, because we are not an OTP, we do provide both buprenorphine, both forms of buprenorphine, as well as the antagonist, naltrexone, to support recovery from alcohol use disorders for the naltrexone, and then opioid use disorders, naltrexone and buprenorphine. And then we partner with methadone facilities if a patient wants that methadone. Next slide, please. So we really believe in taking care of the whole person and not just narrowly seeing substance use disorders in isolation. So we think that it's important not just to give a medication if we're talking about opioid use disorders in isolation, but to make sure that they have medical care, headed to medical care, referring to family medicine. We have a wonderful relationship with them at UNC, for example, and then also making sure that case management is happening so that patients can get their social needs and other types of needs met. Next slide, please. Nope, you can continue. So what do our residential services provide? On average, our families stay for 9 months. There are many times when we give extensions, especially when someone has been on the housing list and is almost ready to get that voucher, or maybe their apartment is going to be ready for them at the end of the month. So there is flexibility. I like to think that we're person-centered rather than just counting the time on a timeline. So you can see there, I've talked about a lot of those things that we do. We do urine drug testing, and we really see that as a therapeutic tool and many of our women say that they like having that, so it keeps them accountable and also can show their success, not only to themselves, but sometimes Child Protective Services when that is a relevant issue. We do provide transportation to and from the program. We have a wonderful cadre of peer support specialists. Many of our former graduates actually now work for us. And so that's really wonderful to have that model of lived experience to be part of our team. Let's see. And then shared decision-making is another piece that's really important, so that treatment isn't something that's done to someone, but it's really there in the driver's seat of their treatment and what are their treatment goals and how can we best support them. And so those could be anything from, alcohol and drug abstinence, employment, legal issues often are things that are really major problems for women, and help to resolve those, or at least come to some kind of better space when they leave than when they came in. And then the physical and mental health, child outcomes. Many times we see the children that come to us on average might be somewhat delayed in their developmental milestones, and giving them that stability and helping mom get healthy and the children have predictability in their lives. We often see that children not only meet their milestones, sometimes they exceed them. And then also what we can do with Child Protective Services to get those cases resolved. Next slide. Nope. Sorry, keep going. All right, and so we not just talk about the absence of illness, we also talk about wellness and recovery. And many of our groups are centered around those 8 dimensions of recovery and what that looks like for women. Like just last week, we did vision boards talking about those 8 dimensions and what women want. Hope for recovery, and the language and person-centered language around recovery. So the words that we use really matter, and the words that women say to themselves and to their children also really matter. So there's a lot of focus on what does it look like to be well? What does it look like in the dimensions of recovery? Not just abstinence from substance use, but all of the other healthy pieces of our lives. Next slide, please. So we use a number of evidence-based curricula to provide particularly both group and individual treatment. And so you can see those on the slide, I think, and maybe our 2 panelists will also talk about dialectical behavioral therapy, which really kind of, as we do exit interviews, that seems to be a set of tools that are incredibly important for helping women stay well. Next slide, please. So one of the unique things about our program is that we have a dyadic model of care. So we don't just focus on mom, or we don't just focus on the child. We really focus on that space in between, that relationship between them. So the services that we provide specifically for the children is childcare. We have access to psychiatric services for children if that's something that's needed, and then those early intervention services. And one of the really nice things that happens in our Child Development Center is that we have contractors that can actually come on site and provide that OT or PT or whatever those services are that the children need. And so then our child care workers are there and involved in that. At times moms can come in and be involved in that so that they're really learning what's happening with their child and then can practice it at home. Next slide, please. So there's just a little bit more about those therapeutic services. You can see there that I've already said that they are screened and assessed. And we know that many of the children need these services. They're going to qualify for those services, and luckily the vast majority receive them. Next slide, please. Yep, next slide. So what is our postnatal protocol? So we have Yvette Horton, who is our maternal child therapist. She's supported by the UNC psychology program, where we have a set of interns and then another maternal child therapist that also works with us on a limited time basis. And so Yvette will go in and she will see our moms and after they've delivered their baby. We're actually going to be talking about things prenatally too. And so she'll be there, she'll be seeing mom and baby, and we really focus on mom's strengths. We talk a lot about what are baby's superpowers in terms of crying and what those different cries might mean. We work on bonding, we work on eye contact, we work on swaddling, all of those wonderful things to help mom feel empowered, because mom, particularly if we have babies that have experienced withdrawal because they've been prenatally exposed to opioids and other substances, mom needs that support to know how to respond to baby's cues and how to best soothe baby. Next slide, please. So what are our successes and how do we measure that? Obviously through the personal plans that we have and those treatment goals, that shared decision making is happening. Substance abstinence is an important part of our goals. We have the housing and employment. For some women it's education. For some women it's getting their driver's license back so that they can attain those educational goals that they have or become employed. Obviously, resolution of CPS cases, resolution of legal status cases, birth outcomes, I'll share a little bit of that, increases in parenting knowledge and practices, as well as coping skills. One of my favorite quotes from a patient that we had a number of years ago said, you know, Dr. Jones, I came in with a pocket full of pills, and now I'm leaving with a pocket full of skills. And I can not only be physically present for my child, I'm emotionally present for my child, and my child tells me that. Client satisfaction, so we routinely do those repeated surveys to see how patients are liking our services and what we can do better. And obviously child outcomes are important too. Next slide, please. So this is just an example of how we measure success. And so even just with the lowest level of care that we provide, which is that perinatal, comprehensive perinatal clinic that we have very low rates of prematurity and low birth weight that you can see on the slide. And when you compare that to untreated drug exposed comparison groups, you can see that we do much better. And we're at least on par with the state, not the state population, if not sometimes better, depending on the year. Next slide. So our graduate family outcomes for our families that complete treatment with us, 77% of them are leaving with a job. Now that is pre-COVID. We've had a much greater challenge helping to support women with employment during COVID. And then 95% of our residential families either maintain their child protective status, positive status, or improve their case status. So that means we're getting moms and children back together and closing cases. Next slide, please. So a back of an envelope calculation, and we actually have private funding to be able to systematically look at this. So if you invite me back in the next 2 years from now, I'll be able to give you final data. But we do estimate by avoiding foster care, by avoiding incarceration for women, by avoiding long NICU stays, by avoiding emergency department visits, that we estimate that we can actually save North Carolina well over $3 million every year in cost of maternal child care. Next slide, please. And so our model has been, pieces of our model have been taken and adapted all around the world. I was actually just listening to a grand rounds in the UNC Pediatrics this morning, where a couple of years ago, folks from South Carolina came and looked at our model, and they've now adapted it for themselves. So every place from Australia to Afghanistan is actually taken pieces of our model. So I think that's really wonderful that they don't just take it and it's not a cookie cutter approach, but they take the things that really work for them and apply it. And our whole goal is to help improve the lives and well-being of women and children who are affected by substance use disorders. Next slide, please. So what are those lessons learned? Certainly there, for so many years and decades, actually, there's been such an emphasis on deficits, on weaknesses, on risks. And we really need to take an opposite approach, because clearly that hasn't worked. We can't sort of punish our way out of the illness of substance use disorders. If we could do that, we wouldn't have a problem. So we need to take the opposite approach and really look at what are the strengths and the aspects of resilience that our mothers and children have, and how can we build on those. Making sure that we are using person-first and person-centered language in all of the work that we do, not only just with the patients that we have the honor of serving, but also between colleagues. And pictures and visuals matter. And so I encourage everybody to look around your work setting when, where patients are going to interact with you or interact with others. And what are those pictures on your walls? What are they conveying? What are the statements conveying? How are the rules listed? Are they kind of stated in kind of a more punitive way, or are they stated in an empowering way? Help tell stories of success and recovery. So often we only hear about the sensationalized negative stories, and there are so many stories out there of people. We just heard from Jude. People can and do recover, and there's so many out there. So I encourage you to share those stories when it's with confidentiality or with permission, obviously. And to, when we're doing this work, to not just focus on the mother or not just focus on the child, but really focus on both. It can be an and, it doesn't have to be an or. There are a tremendous number of toolkits out there that you can look at and you can take. ACOG's got a wonderful state legislation kind of toolkit for how to be an educator and advocate. The SAMHSA has a great dyadic guide for how to support and empower women who are pregnant and parenting and their children, where the women have had opioid use disorders. I think, one of the things that we continue to struggle with is tobacco cessation, and what are the right ways that we can support women in reducing and stopping their tobacco or nicotine use. Making sure that we're advocating for that compassionate care. Every single one of us on this call has a role, and we can advocate for compassionate care, and we can be role models for compassionate care. And then making sure too, we have an incredible crisis around maternal mortality in this country that continues to rise. And that is so true in the state of North Carolina as it is in other places around the country. So making sure that we are really actively listening and responding to pregnant and post-pregnant individuals when they tell us something is wrong, really listening to their signs and their symptoms and making sure that they are getting that care that they need. And thinking about substance use disorder treatment through the lifespan. So often we focus on postpartum period, when we know that, on average, the women that come to our program started using substances at 15. So I really see substance use disorders as a pediatric illness, and we need to do a better job really focusing on younger individuals for prevention and also for access to treatment. And then finally, working towards eliminating stigma and discrimination against those that have substance use disorders, especially those that are pregnant and parenting. And with that, I'm going to close, and I'm going to introduce Susan and Olivia to share. And if you want to, sorry, one more thing. Here are some key documents in case you're interested in learning more. Horizons has had the privilege of contributing to all the documents that you see on the screen. So we are known as not only a national model, but an international model for the way to work with women and children. And so with that, now I'm going to talk. I'm going to introduce Susan and Olivia. And so Susan and Olivia, if I could invite you to turn on your cameras if you're comfortable with that.
I didn't realize my camera was off this whole time.
That's all right. No worries. Thank you all so much for being here. So it is my honor and privilege to introduce to the audience Olivia and Susan, who are going to share their stories about kind of how they got to Horizons, what Horizons has meant, and most importantly, what lived recovery looks like. Who would like to start?
I'll start. Hi, I am Susan. I am 38 years old. I'm a mother of 2 little boys, and I just had a little girl, Mary Blair. She's 5 months. And so my journey to Horizons, I'll start with, I had a mother who was addicted to opiates throughout my life. I did pretty well. You know, I went to school. I was an x-ray tech. I had 2 little boys. I was on the PTA. And then, you know, I had a tough time with this anxiety that set in. Wrong person, wrong time, wrong thing. And I ended up addicted to opiates. And I, you know, in and out of recovery for a few years. I went to OPDAAC. I was there. It wasn't long enough for me. You know, I always thought if I just got it out of my system that I would be okay. And that wasn't the case. Last February, I relapsed after 9 months clean. And I ended up getting pregnant with Mary Blair. I thought it was the worst thing I'd ever done. I just couldn't believe that, you know, I felt like a disappointment. I felt like one more thing I had messed up, you know. And I was in the Moore County Hospital, and they had offered, you know, to try to find me a program, but my dad and my stepmom offered for me to come home. They turned their basement is a 2-story, it's a 2-bedroom apartment. And that was going to be enough for me. That was enough for me. I can stay clean. I've got this baby in me. I'm a mom to these beautiful little boys. It was going to be great, you know. Until June, I felt very trapped. I needed to get my license back. I couldn't drive. You know, there were just so many things that I needed to do that I couldn't do. I just felt so trapped. And I relapsed. I relapsed with this little baby inside of me. And I have never, I didn't feel like I deserved to live. I didn't feel like I deserved to be her mom. I was sad, man. And my dad called me one day and he said, Susan, you're killing that baby. And I just said, come get me right now. Excuse me. And he did. He came and got me right then, and he took me to UNC, and he dropped me off, and he said, figure it out, Susan. He said, you're a good mom, and you're a good daughter, and you can do this. And I did. I went in, and I had an infection, and, you know, I was in the hospital for about a week or 2. And I kept calling around, and, you know, nowhere. My main insurance is Medicare, but I had recently, you know, I got the pregnancy Medicaid. You know, so when I was calling places, it was showing that I had Medicare, and a lot of places weren't accepting that. So you know, I called Horizons, and the first day they didn't take my insurance. The second day they didn't have any beds. The third day they didn't take my insurance. I just kept calling. And then the 4th day, Deshauna Brooks, the program director, called me, and she said, we accept your insurance and we have a bed for you. And that day was life-changing for me. I was absolutely terrified. They had an Uber pick me up at the hospital and bring me to the program. And they dropped me off at the playground. And the Uber said, goodbye, ma'am. Have a good day. And little did he know, you know, what he was bringing me to. Something about this program has changed my life. You know, the COVID, it's really kind of put a damper, I think, on the program and the ability, just the things that it was, you know, that could have been. But at the same time, what the COVID has taught me is to be still and to sit in those uncomfortable feelings and feel those feelings. You know, they brought me to this beautiful apartment overlooking this beautiful pond. And, you know, I just felt like I don't deserve this, you know. But between the RAs and the staff, and she spoke about Miss Yvette. Miss Yvette is the child psychologist that we work with. They changed my life. They made me feel worth it. They made me feel I'm in a community of women that are just like me, you know. I feel like I've created a family here between the women, between the staff, and then also the groups. I just graduated SAOP on Monday. I graduated SAOP, and Tuesday I graduated the program. So I actually am packing now. I move out tomorrow. And in this time I almost have my license back. I've taken care of all of the court things that went with that. I've applied for the educational funds that Andre spoke about, and hopefully I'll receive that. And that will, that'll be a big hurdle as far as getting my license back. I've paid off my car. I've started school. I'm a full-time student at Central Carolina Community College. And my goal is to become a doula. And I would love to work for the Horizons program. I want to be a doula with an emphasis on lactation consulting. And my goal is to work for Horizons. That's how much this program has done for me. I've learned how to be a good mom again. I've learned how to love myself again. And I have learned, most importantly, that I'm worthy and that I deserve these good things that are coming to me. I don't know where I would be without this program. It was my only option. I had a list of several other programs. Cascades was one of them. Crystal Lake was one of them. But I wanted to come here. I don't know. UNC, they delivered both of my boys. In 2007, I was diagnosed with an autoimmune disease, and they did my heart surgery. And I just felt like this is where I needed to be. They've been, such a big part in so many important things that have happened in my life. And now they've saved my life. I've saved my life with their help. I don't know. I'm so grateful for this program. I'm grateful that I get to wake up every day and I get to be a mom. I don't really know what else to say. I move into my new apartment tomorrow. It's my last day here, and it is I'm so happy, but I'm so sad. Last week I didn't want to leave. I wouldn't pack. I just, I made a life here. I made a family here, and I've had such wonderful support, with the girls, with the staff, with the groups, with everything. I really don't have anything negative at all to say about my experience here. I'm just so full of gratitude. Andre used to talk about that a lot in the group she ran, just the gratitude, and my cup is overflowing right now. I don't know. Wow. I never thought that I would be back in school. I never thought I would, go through the things to get my license back. I never thought that I would be a good mom again. So thank y'all for listening. Sorry.
Listen, if we were all standing in the same room, you would be getting a standing ovation right now. Oh my, Carrie, your incredible story. It is just humbling to have witnessed your incredible growth and your finding your voice and using your voice and your empowerment. It's just incredible. And I hope you take a moment while Olivia is talking to all the wonderful love that you are getting in the chat box. So thank you.
Yeah, I'm actually tearing up over here, because recovery is hard, recovery is not easy, and being a mother in recovery it's just a whole nother level. We feel like we have more pressure on us, the stigma around mothers and addiction is just, but anyway, my name's Olivia, and I'm 33. I have 2 children. I have a 10-year-old son, Caleb, and a 13-year-old daughter named Leah. They're my world. And just now, I've been in the program for 6 months. And just now where I'm at, I see what I missed, and, I wish I could take it back, but, I'm here now, and it's one day at a time. So a little bit about what brought me to Horizons. I've actually been dealing with addiction since I was 8 years old. And, you know, I didn't really have anyone. My parents were both addicts. You know, I went hungry. I went without clothes and lights and heat and water. And, you know, I never really knew what it was like to have someone be there for you until I came to Horizons. Like Susan said, you know, it's life-changing. You know, the chance to be in recovery is a blessing on its own. But to be in recovery and have my child here with me is beyond amazing. You know, I went to several hospitals. I'm from Harnett County, so there's not really, you know, a detox center in Harnett County. And so I really wasn't aware of my resources, my options. And I reached out to the emergency room. You know, I had finally reached my breaking point. And that's the only place I knew to go, you know. So they sent me from emergency room to finally the third one. And they told me about Wakebrook in Raleigh. And they almost didn't take me because I wasn't a Wake County resident, but I was able to convince them to give me a bed. And that's where I detoxed. And that's where I learned about Horizons. And to this day, you know, I still can't believe that I'm here because of how long I have been struggling with this disease. And I would have never thought that I would have come this far just in this short amount of time, and how much I've learned. Horizons has taught me that recovery is so much more than being abstinent from all substances. Recovery includes repairing relationships and like continuing education, establishing a career, mental health, addressing your trauma, and they provide therapy. You know, it's about your physical health, and then the coping skills that they teach you here. So many coping skills. It's amazing. Like with the DBT that Miss Hendrée was speaking about earlier, it's made me a completely different person. Like, it's had a huge impact on how I handle every situation. Like, it's made me a kinder, more patient, and especially a better mother. I'm able to take a step back and break down circumstance and respond in a healthy way, as well as being able to communicate healthy. I can apply everything that I've learned at Horizons and apply that knowledge to every aspect of my life. You know, not just staying sober. Horizons is just a blessing. You know, parenting, and they provide child therapy. Like my son, just seeing how much our relationship has improved. And my 13-year-old daughter, she's not here with me, but like we tragically lost her father a couple weeks ago, and just knowing that I couldn't be there with her was really tearing me apart inside. But Horizons was so supportive, and everyone just came together to support me in that time. And I was able to go to the funeral and be with her, and I'm forever grateful for that. That was such a hard time for me and for her, and I was able to, with what Horizons taught me and the coping skills that I had, I was even presented with a time at the funeral where somebody asked me to get high with them. And I was able to say no because of Horizons, because of what they instilled within me to be able to say no. Before I came here, I wouldn't have been able to do that. So it's just amazing to see. And then all the other women here and seeing all the growth, it's just amazing, you know, like me growing up with the traumatic experiences that I've had, and, you know, not having anyone there for me, it impacted me in a huge way. And I'm able to deal with that here. I'm able to go to the places that I didn't want to go, that I've pushed to the back of my mind, and I can do that in a healthy way. Like, and instead of worrying about returning to the real world when I leave, because that was a huge anxiety. It brought a lot of anxiety whenever I was here, and within the first couple months. When you're in active addiction and you think about coming to recovery, you're like, oh my gosh, 9 months is forever. But then when you get here, you're like, 9 months is not enough. Like, I want to stay longer. Like, because it's such an amazing program. And, now I'm getting closer to feeling capable and ready to join society and create a life that Horizons has made possible. I have people out in the community that I've set boundaries with, but I totally recommend this program to them because they're mothers as well, and they need the help, But it's just been an amazing journey. I still have 3 months left, and I plan on just soaking everything in that I possibly can, because everything that I learn here, I can take with me. And with my children, I pass the skills that I learn on to my children, because like I said, you can apply it to any circumstance. The anger, he has anger issues. He's grown so much with his anger, and I'm able to be patient and kind with him. And it's made such a difference. It's made all the difference. And so yeah, that's just a little bit about me and how Horizons helped. And it's just been a blessing. I'm so grateful that I came here. I feel blessed to be a part of this journey, here with Horizons. And I feel honored to be here with you guys today, to be able to share my story. But thank you for listening. Yeah.
Thank you, Olivia. Again, just amazingly beautiful. Thank you so much for sharing your authentic self with us, because it is a beautiful, authentic self. And we really appreciate it. And you're getting all sorts of love in the chat box too. So take a moment to soak all of that wonderful support in. And thank you both. Round of applause. I'm standing up and cheering. So, Margaret, are you going to be leading us in the Q&A?
Yes, I will. And we'll get that started. But before that, I just want to say thank you, Andre, for your presentation. Always really good to hear from you and about Horizons. Special thanks to Susan and Olivia. Everyone was moved, including me. Glad my camera was off because I got to crying. Your stories are really special. And so we are fortunate to have you guys here with us today to share. All the best to both of you.
Thank you so much. It was an honor to be a part of this panel. I love, I don't know, just sharing a little bit of, I don't know, just trying to make a difference in the world on how people look at addicts. And it was an honor to be here. Thank you.
Thank you both. So we're at the question and answer portion, and I'm going to do my very best to streamline this, but I know that some will be specifically for Dr. Johnson about Horizons, and others are pretty broad, and I think both Judith and Andre could answer those. So I'll try to sort it out, but I am not perfect. I'll do my very best. One of the ones that I saw that was especially for you, Dr. Johnson, it was earlier up. I'm looking for it now. There's a program that you mentioned, and so it was within your presentation, and it's from Jerry Madison. She's asking you the name of the agency you said that Horizons is partnering with to address housing, and yeah.
Yeah, so I'm happy to share a little bit more about that. So this has been a long work in progress. Our vision was to be able to have our residential treatment community embedded with, I'm still going to use the word transitional housing. I know that is sort of like a taboo word, but housing, we'll call it graduate housing. So because the biggest barrier that I see our families face when they leave is, where do you find a safe and affordable place to live? And because we're in Orange County, where we have Chapel Hill and Hillsborough, and Carrboro, it's super expensive. And so what can we do for our families to help support them in that? And so we had a capital campaign looking for private funding or foundation funding to be able to build a building. So that we can move our treatment program, because right now we pay market-based rent to apartment complexes that are obviously for profit. And we've done that, since 2001, and it's expensive. Rent goes up every year. Our block grants don't necessarily go up every year. And so we want to kind of move towards that permanent home for our program, just like we want our families to have permanent homes. So we have partnered with the town of Chapel Hill and CASA, which is a program that is specifically focused on affordable housing, as well as self-help, which is also all around financing for affordable housing. And so with their partnership, we are marching forward, and money has been secured. The initial grant has been secured to be able to break ground on that, following all of the approvals that have to happen in the town of Chapel Hill. So hopefully in the next couple of years, we will be able to have our treatment program permanently housed, and then approximately 16 apartments that would be for graduate families, so that they can move into that apartment at a much reduced rate, so that it gives them sort of a softer landing pad to be able to get that sustained employment experience to build up that nest egg that they need, so then they can take that next step to more permanent forever homes. But at least we can help ease out that landing plane for them.
That sounds amazing. Thank you. This question, and you addressed it some, but this could also be open to Judith about other programs that accept patients who are on methadone.
All of the women's programs that are in that network, the state programs, accept women that are on methadone or buprenorphine or Subutex. It depends. Well, some are able to provide it at their facilities, but the programs that they're going to, or they use partners, community partners, but each program does. We had only 2 programs that didn't, and there was training that went out, and we helped them get connections in their community. And so that's been maybe a few years now, and all of them accept women on medication.
If I could just add, I think one of the conversations that's happening in the United States, which I think is a really important conversation, is around methadone regulations. And I think that methadone is the most regulated medication on the planet. And that creates a tremendous number of barriers for patients to access and stay in the life-saving care that they need, so that they have choice of which medication that they want to take. And so during COVID, I think we've seen some movement on, especially for pregnant women. There's wonderful data from Jack McCarthy in California that talks about how methadone doses really need to be titrated during pregnancy, and there need to be conversations and perhaps blood levels taken to make sure, and maybe the dose needs to be not given once a day, but maybe even sometimes up to 4 times a day, the total dose split divided into 4 doses. And so that's incredibly difficult for programs to do if they're limited hours or they don't have the staffing to be able to support that. And so I hope everyone's aware of the conversations that are happening, and I hope you'll join in to that to help advocate for legislation and requirements that make sense, that are person-centered and really respond to the needs that patients have.
Thank you for that response. Appreciate you. Research out of Massachusetts shows that there is an increased risk of overdose 7 to 12 months postpartum. How do you integrate overdose prevention into your program? So one example given is naloxone available, but I'll say programs to see if Judith has a response for this question as well.
Hendrée can answer that, but all of the programs have access to naloxone. And I know there's training around, the old language is relapse prevention, but return to use. So each program implements that.
Yeah, just to give one example from UNC Horizons, one of the things that our integrated perinatal care program does is make sure that we're co-prescribing naloxone with the agonist medication. We also have conversations about overdose, and we do have naloxone available, obviously, in the programs too. And we also help support family members if they need to get that type of support for themselves or for their loved ones.
Thank you both.
And I guess just a shout out to the NC Harm Reduction Coalition. Way back in the day when we started this, I will never forget and will be forever grateful for them coming to our program and spending a lot of time with our women, showing them how to use the naloxone if they ever needed to. And then we kind of took the training wheels off and we were able to do it on our own. But thank you to them for providing that initial education to us.
Thank you, NCHRC. And so I'm going to try really hard with this question, but recognizing that I may need to call on Jerry to explain it more. It says, does Horizons have a specific adolescent health program, meaning developmentally appropriate and tailored services for adolescents who come into care? And I am assuming that we're talking about pregnant adolescents, possibly.
So I'm not sure if Jerry wants to add more.
Yes, I'm not.
So we don't treat adolescents. Our literature doesn't support that. I would love to. It's a future point in time, but right now we take people that are 18 years or older. So I think she might also be talking about the children themselves. Yeah. And so that really care that can be provided for the older adolescents that are not living in residence because of that 12 years and younger is really going to be on an individualized basis, talking with our maternal child therapists like Yvette Horton about what kind of services are needed and what they can be referred to in their home community if they're not living in this community, or what services we can help provide here. But it really is on a kind of case-by-case basis. We don't have a systematic way of taking care of the older adolescents. And that is definitely a barrier. I mean, I love the idea of truly family-centered services. The other thing that hasn't been mentioned are partners. And I really appreciated Jude mentioning the resources there for partners, because that is something that we definitely see that, when partners are in active addiction, it makes it such a challenge for our family members who are engaged in our services to stay well. And so, just an acknowledgement of the need that is always there, and the thankful and gratefulness to partners to help us do that work.
Yeah, thank you. So I have a question. Are there...
Hey,
yes.
Can I just answer a little bit about also the adolescents? When we get calls about pregnant adolescents, girls.
This is what I was going to ask, Jude. So thank you so much.
I refer them to PORT. They serve pregnant adolescent girls. And also there's a program that I visited in Greensboro called Youth Focus. It's not specific to substance use, but what they're able to do with the pregnant mom is to connect her to outpatient care, where she does her counseling for treatment in outpatient and then lives within this facility. Very nice place too, and they've been around for many years.
Thank you so much. Definitely wanted to know if there was services available, and I'm not sure how large that population is, but I know that that's a population. What is your treatment completion rate for those who enter the residential program? Again, I believe this is for you, Andre, but both of you will be allowed to answer.
Sure, I'm happy to start, and if Jude wants to add on. So one of the things that we're really excited about is that we finally have private funding to be able to systematically follow all of our families that come into our care that agree to sign consent to be followed, which we actually haven't had anybody refuse us thus far. So in a couple of years, I'll be able to give you, peer-reviewed published data on this, but right now it's just program level data that I'll give you. And it's about 75% of the families that come in complete treatment with us. And so that completion is determined based on not completing 9 months, but if they have an opportunity. So we have women that, especially during COVID, for example, came in and then completed a large portion of our services and then wanted to finish up on an outpatient basis. And so we allow that flexibility, and we consider that family a successful completing family in the fact that we're responding to their care. So.
Thank you. So this is the end, and so go into the next portion of the meeting, but this is something that I think is really important. And so stigma came, this will be our last question, and some of these things maybe we can address later in a different format if Andre and Judith are open to that. But stigma came up a few times in this presentation. Can you speak a little more about how stigma is a barrier to care for pregnant and parenting people who use drugs or who have substance use disorder, and how can we overcome and address stigma?
Judith, do you want to answer that first, and then I'll tag on? No? Okay. Okay, I gave you the opportunity. Yeah, I mean, I think that stigma and discrimination are just rampant, unfortunately, still even today. I think when we look at the arc of legislative policies that have been put into place, we see this really interesting thing that's happening in the United States. On one hand, we're seeing the arc bend towards a more liberal relationship with marijuana on the state level. And at the same time, we are seeing even more punitive policies specifically targeted to people that are pregnant and have been found out to be using drugs or have disclosed that. And that is just an incredible problem. So what can we do about it? I think in every single medical school, allied health professional school, dental school, social work school, nursing school, anything, any school where learners are going to be interacting with people that might have a substance use disorder, they need to be learning about substance use disorders as a medical illness for which there is treatment, and talking about the language around person-centered language and around recovery, because it absolutely starts with our words. It also, we need to hold media accountable. You know, so much of the media is driven by sensationalized, you know, eyeballs and clicks. And where can we dial that down to have a more compassionate approach rather than this like really negative, punitive, visceral, just plain mean approach that needs to stop. And that stops with all of us, right? I mean, it starts with our own community supporting each other in the work that we're doing. It starts with sharing those stories of success. If every single person on this webinar starts using person-centered language and supporting us all in the work we're doing, not tearing each other down, then we're going to be making some amazing headway.
Thank you so much. And thank you both again. And again, thank you, Susan, Olivia. This was really great. We appreciate having you all here today to talk about this very important topic. Carriedelle Fusco is going to talk next about academic detailing project at MAHEC. We stole a few of your minutes, Carriedelle. I say take them from Alan, and so we'll make up for it at the end, okay? Thank you.
And I can keep it brief, and that was such a great conversation, and I was perfectly happy for you guys to take a few of my minutes. So I'm Carriedelle Fusco. I'm a family nurse practitioner. I work up at MAHEC in Asheville, and I've been here for just under a decade, and I started that work around better managing opioids and chronic pain, which has moved into buprenorphine and treating substance use disorders and doing a lot of educating around that work. And I'm going to just briefly talk to you guys a little bit about some work we are expanding at MAHEC and with the North Carolina Medical Board, which is academic detailing. It's for those of you who aren't familiar with that term, it's basically like a peer-to-peer method of outreach that focuses on providing prescribers with the most up-to-date evidence-based treatment guidelines. So I know a lot of you guys aren't surprised to hear there's a lot of work still to do with academic detailing and opioid prescribing and possibly also buprenorphine prescribing. So traditionally, this has been sort of a peer-to-peer, face-to-face model, so that I would or one of my colleagues would go to an office and sort of like in that traditional way that we used to know that drug representatives came and would sit down over lunch and whatnot and talk about medications. Well, this is more of an academic, evidence-based, but similar approach. So face-to-face was the way it's been done for a long time. But like everything else, we're all transitioning to this Zoom phone model, which I think is really great in a lot of ways. We've all, I think, gotten really comfortable with connecting in this way. But basically the goal is to improve prescribing habits around certain medications. Specifically here, we're talking about opioid prescribing. So basically helping prescribers out there who are really struggling to manage a panel they either have had for quite some time or perhaps they have inherited, how to taper and more safely prescribe opioids, do naloxone prescribing, consider buprenorphine, that sort of thing. So I don't know if anybody has any questions about that, but that's just short synopsis of what academic detailing is.
Thank you so much, Carriedelle. I'm not sure if folks will have questions, and if you want to share your contact information, I know a week from now, Sarah will put out this recording and the slides or any information that you want to share. If you have a presentation about academic detailing or a one-pager, I'm sure Sarah would be willing to share that then. And so if you have contact information, folks can get in touch with you.
Absolutely, Sarah. I'll have our team pass along the appropriate contact information so if folks are wanting help with this. But we would love to be a part of helping people more responsibly and safely prescribe opioids and add buprenorphine to their practice.
That sounds great, Carriedelle. I appreciate it. And I appreciate all the speakers today. And I just wanted to kind of end our meeting. For those of you who are not aware, our fearless leader, Alan Della Penna, is going to be retiring in a few months. And this is most likely his last OPDAAC meeting. And so I'm going to try really hard not to tear up. This has been an emotional meeting. But I just want to say thank you, Alan, for all the work that you've done with OPDAAC over the past 4 years that I've been here and then the previous years before I came on. You are such a great MC and you are going to be truly missed, and you have some really big shoes to fill, or the person replacing you has some really big shoes to fill. So I just want to say thank you for all your work with us. And I'm sure that a lot of people on this call also feel the same way. And so thank you so much for all that you've done.
Well, thank you, Sarah. I wasn't expecting that. Appreciate it. It's North Carolina has so many great dedicated professionals. It's wonderful to be part of this community, and I really appreciate working with everyone. So I have to transition out of the meeting, and I think one of the things that was the plan at the end of the meeting was to mention the summit coming up. I don't know, Sarah, if you had the, I think we were going to put in the chat the registration information. So
Alyssa's done that.
Okay, yeah. Also wanted to just acknowledge each time we do one of these meetings, we have a team behind the scenes that just puts a lot of thoughtful time to coordinate with the speakers, to coordinate the presentation, the logistics, to make it all happen. This week, Margaret, Alyssa, Sarah, and I'm sure I will miss many folks at Women's and Children's Health like Jerry, or Division of Mental Health like Starlene. But for this meeting, a lot of work went on and I really appreciate it. And I also just wanted to acknowledge that we have been very fortunate when we shifted to the pandemic environment, that we had a great partner at Governor's Institute on Substance Abuse with Paulin and Alex behind the scene helping us do the platform. So thank you. The registration information, we try to make it really easy to attend this summit. Very inexpensive for a couple days of great information for folks across the state. We're focusing on health equity in the opioid epidemic and polysubstance use at the summit this year. So please register. Lots of great work going on behind the scenes. Holiday weekend coming up. Cold tonight. Beautiful day to hunt for Easter eggs on the weekend. So please take a little safe time to do that for everyone. And thank you for all our speakers and all the time.